Well, good late morning, early afternoon. I'm Jeff Potma from Boston. I'm with Lars Sundergaard from Denmark. This is a good crowd. I think we're going to have a good an hour and a half of work. We have a very esteemed panel. Becky Hahn from Colombia, Philip Lourdes from Germany, Marco Maitra from Italy, Holger Neff from Germany, Hendrik Trede from Germany. Welcome, panelists. We're going to get into a lot of discussions here in a moment. But let's go ahead and start out, I think.
Yep. So again, this live demonstration is going to focus on the Edwards PASCAL transcatheter valve repair system. So the objective is to learn more about this relatively new device on the market, and also to understand how imaging is playing an essential role in planning and also executing these procedures. We're going to Toulouse to see a PASCAL case, live case, step by step. And finally, we're going to end up with some cases where the PASCAL system had been used in different kind of mitral valve anatomy. So I think let's start. We already heard about here who's part of this session. So let's invite Holger Neff to give an overview of the PASCAL system before we continue.
So, dear Chairman, dear ladies and gentlemen, good morning. It's my pleasure to report on the newest innovation in mitral leaflet repair with the PASCAL repair system, and also to share with you the latest results from the Clasp study. These are my disclosures. Well, the PASCAL implant contains of 3 differentiated features for efficacy and safety. And one of them is the central spacer with a width of 10 millimeters, which is surrounded by these broad contoured paddles, just to allow to attach the leaflet to the spacers, and the clasps which are hidden in this PASCAL device here. The PASCAL delivery systems also consist of 3 components. First, the guide sheath with a 22 French guide, which is hydrophilic, and the steerable catheter allowing to maneuver in 3 independent planes. And finally, the implant catheter for heading directly to the mitral valve. Once you have inserted the catheter system, so you are able to steer the catheter in different planes for the versatile navigation, and you have also the ability to gain height to be perpendicular to the coaptation. I think one very unique feature of the PASCAL device is that you can have the steering independently of your class, so you have an independent leaflet capture. So you can either stage, your leaflet capture in a staged version, but you also have the possibility to fine adjust your position, even if you have captured a leaflet already. I think this is a very unique feature which comes with this new technology. Also, the spacer is enabled, the spacer enables a shorter coaptation distance, so therefore it uses the pull forces on the leaflet. And I think finally you have the possibility to elongate your device, which helps your maneuvering subvalvular in a very easy way, and you are not you are not in a danger to be caught by the chordae. This is a short case presentation of a mixed pathology, not only FMR but also DMR, and you can see the atrial dilatation with a A2 flail leading to this severe mitral regurgitation. This was fixed with only 1 PASCAL device. As you can appreciate here, it was a very sufficient reduction of DMR after implantation of the PASCAL device in the A2 P2 position. The This brings us to the Clasp study, which was a single-arm, multi-center prospective study to evaluate the safety and performance and clinical outcomes of the PASCAL in patients with a significant mitral regurgitation. The study endpoints were the primary endpoints of safety, which was a composite of major adverse events, including cardiovascular mortality, stroke, myocardial infarction, new need for renal replacement therapy, severe bleeding, and re-intervention for study device-related complication. And we looked also at the performance of the device, which was documented as a device success, procedural success, or clinical success. The secondary endpoints include all-cause mortality, composite of major adverse events, mitral regurgitation reduction, change in New York Heart Association functional class, the 6-minute walk test, and overall the change in quality of life. These are the patients which were included into the trial, overall 62 patients. The 6 months follow-up was completed by 57 patients. The results are already published. However, I want to go through shortly with you just the study demographics. The mean age of patients was 76 years, 37% were female. The majority of patients, 51%, showed a New York Heart Association functional class of 3 or 4. Looking at the etiology of the MR, majority of patients showed a functional MR with 55%, degenerative pathology in 36%, and a mixed pathology in 8.2% of patients. So looking at the procedural characteristics, there was a successful implant rate of 95%. In 3 patients, the implantation failed. 1 patient due to a single leaflet device attachment, and 2 patients, there was the PASCAL implantation was not able to perform due to anatomy reasons. The mean number of devices implanted was 1.4, and the time of procedure was a little bit more than 2 hours skin to skin. This is the primary endpoint at 30 days with a cardiovascular mortality at 1.6%, no stroke, no myocardial infarction, no need for renal replacement therapy. There were 4 severe bleedings, 2 GI bleeds, and 2 excess-related bleeds, and there was 1 re-intervention for study device-related complication, which was a single leaflet device attachment, which was converted and successfully performed by the surgeons after that. So overall, we have a composite major adverse event rate of 6.5%. These are the results in terms of MR reduction at 30 days and 6 months. Looking at 30 days first, so 98% of patients showed mild to moderate mitral regurgitation and below after 30 days. This result sustained over 6 months with 98% of patients with a mild to moderate mitral regurgitation after 6 months. A very important question is the hemodynamics in these patients after implantation of the PASCAL device. Looking at the mean transmitral valve gradient, you can appreciate that the mean gradient was 4.1 at discharge. Also, this gradient sustained over 6 months with a 4.0 millimeter of mercury gradient after this follow-up. Of course, the excellent reduction of the mitral regurgitation was associated with an improvement of the functional status and exercise capacity also in 6 months. Looking on to the 6 months results, you can appreciate that 88% of patients was in a New York Heart Association functional class 1 and 2. Looking at the 6-minute walk test, so this was significantly improved after 30 days. However, after 6 months, you have only the trend, but it was sustained. It's my privilege to share with you also the latest results of the Clasp study, including the 26 patients with a 1-year follow-up so far. And this is the composite endpoint after 1 year with a composite major adverse event rate of 10%, cardiovascular mortality 3.3, but only 1 patient out of 30. This is the Kaplan-Meier curve for survival and heart failure hospitalization rate at 1 year, which was 93% and 86% respectively. Also, again, the MR reduction was excellent, looking at the 30 days result of these 30 patients, showing that 96% of patients was in a grade moderate, mild to moderate, and below. Unfortunately, one patient deceased, so 100% of patients after 1 year showed mild to moderate mitral regurgitation, and looking at these 74% of patients having only a none or mild mitral regurgitation after this time frame. So, of course, there was an improvement of the functional status and exercise capacity. The New York Heart Association functional class was shown here, and you can see that 92% of patients were in status 1 and 2 after 1 year. Again, the 6-minute walk test tends to improve, however, it was not statistically significant. Overall, we have this change in quality of life at 1 year, and we have looked for the Kansas City cardiomyopathy questionnaire and the Q5D questionnaire. And again, you have this significant improvement after 1 year in both of these questionnaires. So I like to conclude the PASCAL transcatheter valve repair system is a novel and differentiated therapy for patients with MR, showing safety and efficacy in the CLASP study. At 30 days, 6 months, and 1 year, the major adverse event rate was comparable low. After 1 year, MR reduction was substantial and sustained. Overall, the mean mitral valve gradient after implantation was 4 and remained stable. There was a significant improvement in the functional status, and of course, we have to continue these follow-ups and to complete, and there's no doubt that we need some randomized trials, but they are underway. Thank you very much for your attention.
So, Holger, if you stay up for just a second, let me just ask a quick question, then I'm going to turn it over to Lars for a discussion with the panel. Because I think we have a couple minutes to be able to ask this. In our randomized trial in the United States, we've got a FMR trial and a DMR trial that are randomized. We have 2 learning curve cases, and then we're good to go. I kind of have felt like that was enough for proficient MitraClip centers that would come in and learn this technology. Did you see any learning curve in the early experience here? Any tips that you would want to give to the audience about how to do this well?
Well, of course, there are a lot of difference regarding the 2 systems, and there is a learning curve, obviously. So you have to handle the catheter system, the delivery system, which is completely different. I think 2 cases are not enough to have this learning curve and to do the case properly. So in my experience, I think you need 10 to 15 cases, and this might be a good number that you are familiar with the behavior of the device, which is, as I said, completely different.
So thanks a lot, Holger. But also, Holger, you touched about this independently grasping. So can you tell where could that be an advantage to have that?
Yeah, that's one of the unique features. If you have these tethered leaflets, so you are able to grasp first the AML and then just to change the trajectory for the posterior position, and then you can grasp also the PML very properly. So this is a very unique feature which helps a lot in different anatomies, and I think that could be one of the advantages of the device.
Okay.
Yeah, I think in our experience also, one of the best features was being able to get the device out of the ventricle when you want to reposition.
Can you just explain what's advantages here?
I mean, the advantages are if you're doing a non-A2P2 defect, and so if you're in the commissures, there's an arcade of chordae that come up into the commissural commissure, and if you get caught in that, this device, you elongate, and I mean, knock on wood, but there's not been a single case we've not been able to withdraw, reposition in the atrium, and come back down.
That's an improvement for the safety of the procedure. Yeah. So maybe we should just talk about the case now, and we can talk about what treatment options are for this specific case.
Perfect.
So again, this is a patient with degenerative mitral regurgitation or primary mitral regurgitation. It's a male, elderly male, 87 years of age, normal size. He got a history of hypertension, dyslipidemia. He's very active, or used to be active, but he's now limited in his activity due to heart failure. He is cognitive well preserved. He had a history of ischemic heart disease and underwent PCI in 2009 and 2017. And he also had one RF ablation for atrial flutter. He was recently admitted with acute heart failure, pulmonary edema, and on diuretic he's still in function class 3. His labs tests are normal. You can see he's in severe heart failure. His NT-proBNP is more than 6,000. And he is on diuretic, ACE inhibitor, and also get a NOAC due to his arrhythmia. We're going to look on his imaging in a minute. Becky is going to show that, but just summarizing here, echo showed mildly impaired LV function, ejection fraction is 45, but keep in mind he got severe mitral regurgitation. It's not too big, his left ventricle, he got severe mitral regurgitation, and it's based on a rupture of a cord, which is causing a P2 prolapse. His right side is preserved function, and he got no sign of severe pulmonary hypertension. ECG here, atrial flutter. And if you calculate his risk score, STS score 7.5, so I would say not only got he got a high surgical risk based on his STS score, but he's also 87 years of age. So just to summarize, elderly gentleman, he used to be very active. He got a relative good life expectancy. He got severe degenerative mitral regurgitation based on a P2 prolapse, function class 3 despite optimal medical treatment. He got a high surgical risk score. So Becky, maybe you can show a bit more about the images, and we can talk about the different treatment possibility for this gentleman.
Now, and Becky, we had a question from the Time to React about where to do the transseptal puncture. So if there's any chance when you review the images to talk about the septal puncture, or we'll talk about it after.
No, I mean, I can talk about it. I just don't have any imaging from that. So this is imaging from the site. So a little bit limited what we were given. It was mainly just AVIs, so wasn't able to do the DICOMs. But I can share with you our algorithm as well. But this was already stated by Lars. There's an EF of 45% with some global hypokinesis, severe mitral regurgitation, P2 prolapse, and preserved RV function. And the goal of imaging pre-procedurally really is to assess the mitral valve morphology and the mitral valve area. That allows us to know how many devices we can put in safely, because again, a reduction in about 50% of the mitral valve area at baseline will occur with a single device. And then we need to know the coaptation gaps. That will also help us determine which device appropriateness, but also how many, and then obviously the severity of the disease, because afterwards, sometimes these patients, the results and success need to be determined in the context of that patient clinical scenario. So sometimes we'll have torrential disease in a flail that's on a balloon pump, and we may be satisfied with mild or moderate regurgitation in those cases. So all of that is determined pre-procedurally with imaging, and this was just from our site, our idea of what was ideal, which is really the Everest criteria, and then the challenging echo features, which is pretty much anything outside the Everest criteria, and then those that remain very, very difficult and therefore relative contraindications. But again, in the setting of good imaging, we can frequently do all of these morphologies. And what we're talking about today is, again, the degenerative disease. And so the ideal Everest criteria was a flail width of less than 15 millimeters, a flail gap of less than 10 millimeters. In our case, and again, these are just the images that I was given, so you can see, hopefully, a little bit more difficult on this B mode color, but there is a ruptured cord where the cursor has been placed in the biplane image is just a little bit lateral to the midline. So we believe that this is actually a flail just lateral to the A2P2 commissure. And in addition then, if you look at flail gap, we believe it's about, again, usually we would do this on three-dimensional imaging, and we weren't given the DICOM, but clearly you can see that the gap is about 10 millimeters, maybe a little bit more, and that the vena contracta certainly would make severe, and the site had quantified a regurgitant orifice area of over 40 millimeters squared. The three-dimensional color Doppler image is here, and you can actually see the flail on a still frame. Again, from just the two-dimensional imaging of the three-dimensional structure, I estimated the flail width at about 15 millimeters, maybe a little bit more. And so now you have a flail gap around 10, possibly a little larger flail width, certainly greater than 10, and so therefore meets criteria for what we would think might be a challenging case and possibly require more than one device. The site also provided the fact that there's no risk for left atrial thrombus. You can see there's no thrombus in the left atrial appendage. There's no concomitant disease. And the only advice that I would give also is that after the device goes in, that we like to see, evaluate these parameters. So mitral valve area with peak and mean gradients, understanding that the peak and mean for the mitral is very dependent on heart rate. And then we like to planimeter to confirm those, the peak and mean, particularly in the setting of low ejection fraction, where you may get an artificially low mean gradient, but a stenotic valve. And so we'll planimeter on three-dimensional imaging. This is one of our PASCAL cases, a two-device solution, and we planimetered the orifices. In addition, one of the most powerful things that we look at is the reversal of pulmonary vein systolic flow. If you have reversal or blunting that now becomes systolic dominant, as in this particular case, that actually carries with it a much better prognosis. And then obviously looking at color Doppler, and in our case, we also confirmed with relative stroke volumes. As far as the transeptal puncture, if you were to use a three-dimensional image such as this one, we actually use three-dimensional quite extensively in order to target the transeptal puncture right at the medial commissure. And that's possibly the most important thing that you can do to make the device procedure go much more smoothly, is just target the medial commissure. So now when you're scanning across the commissure, remember this is just, we believe, just lateral to the midline, you can now just push the device in to go lateral, pull it out to go medial, and it makes it much, much easier. And so we do all of that using three-dimensional imaging prior to the study. Thanks for your attention.
So, so this patient, Henrik, got a prolapse of the P2 due to a chordal rupture. I guess he's an elderly patient, high surgical risk. You would not take him for surgery?
No, not at the age of 87. No. So surgery is not an option here.
So we're talking about transcatheter-based therapy. So what is the options for a gentleman like this?
Yeah, maybe it's still worthwhile to think about the surgical repair techniques we would use. So in such a case, we would use chordal replacement together with an annuloplasty ring.
Yeah. So Dr. Mensa, what do you think about this? Is it an ideal candidate for repair, and how would you address this patient?
Yes, I think so. I think my role is just to point out the importance of optimal medical treatment. The patient remained symptomatic after the episode of acute pulmonary edema, despite diuretic treatment. And so I think, and he has an organic defect causing severe mitral regurgitation. This needs correction as far as it is possible with the percutaneous technique.
So apart from transcatheter mitral valve repair, we also have the possibility to do valve replacement. So Philip, is it anyone you would consider on your side for replacement, or would it always be a repair approach?
I mean, the repair approach here would be a little bit more straightforward. I guess we would need a bit more imaging to see which technologies would fit in there. A CT would be required, a lot more assessment. But if you have a relatively, or in this case, extremely safe procedure, and you have the feeling that you can get a good result with a repair.
Lars, I think we're ready to go live.
So let's go live.
Live from Toulouse with Nicolas Dumontet and Didier Cheche. Hello, gentlemen.
Hello, friends. So hi, Jeff. Hi, Lars. Hi, Becky. Hi, everybody on the panel. It's a real pleasure to welcome you back here in the hybrid suite of Clinique Pasteur. I have the privilege to work once again with the same team, Nicolas Dumontet, my partner in crime, and I'm really pleased to work with him. We will have also Alison helping us to deal with the device, and Maite will be the second nurse, and David will be the anesthesiologist, and we will interact also with Laurent who is our echocardiographer. So maybe, Nicolas, we can start with the objectives, the key learning points of that
thank you,
case.
Didier. So I think you can directly go to the next slides. We hear a very interesting discussion you had. Next slide, please. Discussion you had about presentation of a case, of the anatomy, of the clinical features that are summarized in this slide and by this echo loop. On the next slide, we will review what we would like to do during this slide case, that is namely to review the key steps of mitral repair procedure with the PASCAL device, and of course to illustrate through that the key features of this device. So we'll work in a conventional setting under general anesthesia. We're using 2D, 3D transesophageal guidance. Given the anatomy and the features of the device, we would like and we will anticipate that we could maybe offer a good option and a good treatment to this patient with one device, positioned at the place of a prolapse. If second is necessary, we'll see. Next slide, please. And we have used for transeptal puncture that needs to be accurate as for any mitral repair radiofrequency transeptal needle. That was really necessary here, Didier, because we'll maybe show that a little bit. We had a very floppy septum,
definitely,
where we can have some difficulties. 2 proglides for vein closure and the PASCAL device. And this is, of course, the team. So, Didier, I think we can start explaining what we've done.
Thank you very much, Nico. So, you've discussed the case, so you know the patient. It's not an extremely challenging DMR patient. So, we aim at placing 1 PASCAL more in the A2P2 region. It's going to be a little bit lateral, as Becky, you just nicely demonstrated. So, we will try to help you understand what are the features. You've described that before. So maybe we can review together what we've done. Nicolas, that's something that I've learned from you. Can you put the fluoro, mettez fluoro, please? So that's something that I've learned from Nicolas when he joined us here. So just after the transeptal puncture, we provide contrast to the patient. It's not a big amount of contrast, about 10 cc's. And then it's going to fill in the left atrium, and you better appreciate what is the projection, fluoroscopy projection of the left atrium, and to be sure that you have plenty of room to navigate. And it seems to be the case here. Yeah. So we are quite satisfied. So the next thing we're going to do, we have done, is to put the guide sheath. Here is the guide sheath that is within the left atrium. And maybe we can start, if we go back to the live 3D echo. What we're going to do is to make sure, Becky, you just on purpose mentioned that the transeptal aperture has to be just on top of the posterior commissure, and it's exactly what we achieved. And now what we're going to demonstrate is to try to remain parallel with the tip of the guide sheath, just to be sure that we are going to navigate in a really perpendicular fashion towards the mitral valve, and then we won't need to correct too much in terms of height, gain, loss, just to be perpendicular. So we're going to see that. So we just wait for the 3D. Tu peux te remettre en 3D. So on that X-plane view, you see the tip of the sheath. And here, you can nicely appreciate that the tip of the sheath is just located on top of the posterior internal mitral commissure. And now what we're going to do is we're going to put the mitral towards 6 o'clock, so downwards. You have the septum. We can see the septum just in front of us, and then we see the tip of the sheath just pointing towards us. So, Nicolas, what I'm going to do is just to flex the guide.
So you're flexing the guide.
Exactly.
JJ, before you start, maybe you can just show the handle, what you have, what possibilities, so people haven't seen it before. So, how can you steer this?
À la place de la fluoro, mettez les mains. Ouais. So here is the guide. So if we enlarge a little bit, vous pouvez élargir le champ. Merci. So here you have the guide. Here is the steerable. There is another component that is aiming at making sure that the trajectory is really perpendicular towards the mitral valve. And if you go more towards Nicolas is going to handle the IC, the implant catheter, that houses the PASCAL device itself. You've seen what are the features of the PASCAL. We're going to show them live. So what I'm going to do as a first step is to activate, if you go back more towards me, to rotate the flex knob of the guide. The flex is going to be, the direction of the flex is going to be projected and represented by the direction of the flex for the flush port. So the guide is going to flex in that projection. And so what I want to do is to make sure that by flexing, I remain parallel to the plane of the mitral valve. So you see it, I'm just flexing. More flex, I'm going more posterior. Less flex, I'm going more anterior, but we remain more or less parallel to the plane of the mitral valve. And this is quite important, just to make sure that you're not going to have too much manipulation on the steerable and the guide at the same time to remain perpendicular. So parallel with the guide, and then the IC is going to be perpendicular towards the mitral valve. So this is very important. It's the first step. And it seems, Nicolas, are you happy with that?
Yeah, I think so, yeah.
Okay, so the parallel plane is okay, so I go back just on top of the commission. So it's fine. So maybe we can put the fluoro live now. Okay, you see the fluoro, and what we're going to do now is to advance everything.
Yeah, so you need to have the echo, the fluoro, and a large view of both Didier and my hands acting on the device. So that's fine.
So as you have everything on screen, what we're going to do is to gently advance the device. We've seen that we have plenty of room within the left atrium. So you see. Okay, so we're going to hand stop here, and Nicolas, if you want, you can start to close. You just focus on the hands of Nicolas. Yeah. He's starting to close the
so by rotating this actuation knob, as you see, I'm starting to close the PASCAL device.
And at the same time, I just extrude a little bit more. Excellent. So the device is closed. So what we're going to do now, Nicolas, is to lift the paddles, the clasps. Lift the clasp just to make sure that then afterwards we remove all the slack that is within the system. Yeah. Because one beauty of this device is that the clasp are able to really follow the orientation of the paddle, so we can really not invert them, but really put them towards the apex of the left ventricle. So the freedom of movement is really impressive. So now on the 3D TOE, what you see is the guide sheath taking access into the left atrium from the septum. Then we have the inner part, the inner catheter of the steerable, and then you see the implant. You see it nicely. Yeah. So now, Nico, maybe we can flex a little bit more. I'm going to flex. Yeah. I'm going to extrude a little bit.
Now the idea, as for any Reaper device, is to define and to find the correct trajectory.
Exactly.
In order to dive at the correct point our targets to a mitral valve. So you're currently flexing.
Yep.
To almost 90-degree angle between the tip of the catheter and the guides. And maybe now, Didier, we have in 3D a beautiful view that will help us, everybody, to understand how you can control this device in 3 dimensions.
Definitely. And this is something that we've learned. We are still in our early phase of experience, but we've been quite surprised by the freedom of movement that you can achieve with the PASCAL. Yeah. And so let me demonstrate that. So, for example, let's say that we are perpendicular. We are perpendicular to the mitral plane, and I want to be more medial. So what I'm going to do is to flex more the IC. Yeah. And the IC is going, as you can see, bending towards the medial port.
So the trajectory, just to be correct on the term for everybody to understand, the trajectory will dive more medial.
More medial. Yeah. So now I'm going to be, I want to move.
Just explain, if you want to go medial or lateral, what option do you have with the system, with the knob and with the pushing and pulling on the system? Can you just explain that?
Yeah. So it's exactly that. So we want to go, so we have several options. So we're going to move anterior, posterior, mainly with the guide, making sure that we are parallel. We are happy with that. Now, to be more medial or lateral, I have two options. The first one is to use the flex feature of the steerable catheter. If I flex, you can see it live. I'm going to go more medial. Okay. You see, it's bending medial, but the trajectory will be medial.
Here we talk about the trajectory, so we'll dive medial.
Now I'm unflexing and I'm pointing towards the the anterolateral commissure. So just you unflex, you're going to go lateral. We're going to go now to what could be, and we're going to test that afterwards, our perpendicular trajectory towards the mitral valve. And by doing so, the other option, assuming that we're perpendicular, if we want to go lateral, we just have to push the IC inward. You see, going lateral, or pull the IC to be more medial. So now that we've done that, I guess, Nicolas, it's time to make sure that we are perpendicular and that we are pointing towards the mitral valve. So I'm going to push a little bit more of the...
Okay. And maybe before, in order to help us maybe refine our trajectory, Didier, we can come back to and explain a multiplane view that will help us to look at our trajectory both in the bicommissural view that you will have on one side of the image, in the LVOT view that you will have on the other sides.
So it's true that the steerable offers various options in terms of really mapping the overall surface of the mitral valve.
So now you have the image on your screen, the echo image. So on the left side, an equivalent of bicommissural view. On the right, almost LVOT view, but not exactly a perfect one.
So Nicolas, just stop here for a second. Maybe explain those two images, what they show, where you are, lateral, medial, posterior, anterior. Just explain what's what here.
What we're going to do is to hand over to Laurent. Laurent, could you explain on the image where is the anterior aspect of the mitral valve, the posterior aspect, and explain where are where is the medial part and the lateral part, please? Just for the audience.
On the left one, on the right part of the left image, you have the lateral part of the mitral valve. Here's the medial part of the mitral valve. And on the right, the aorta is just here. So you have on the right the anterior part of the mitral valve, and here the posterior.
Okay, good.
Okay, thank you. So now the idea is to really look at the steerable and the implant and to make sure that we are perpendicular. Once we have that perpendicularity, if I want to be more lateral, it will be only about advancing the steerable. If I want to be more medial, it's going to be more retracting it. So Nicolas is going to advance now the IC, the implant catheter.
Yeah, and we're just going to test our trajectory.
Okay, so, don't move a little. Okay, I think it's nice.
So with small movements. So you see that I'm diving in a quite coaxial direction relative to the long axis of the left ventricle.
Yeah.
But we have some small corrections to do. On the right image, we see that we're against the posterior valve, so we're going to go a little bit anterior.
So counterclockwise with the steerable.
And on the right image, the overall trajectory looks good, but we see that we are maybe a little bit too lateral.
Okay. So I'm going to add a little bit more of flex on the steerable just to be more perpendicular.
And maybe you will have to pull a little bit on the steerable catheter to go a little bit more medial. Okay, so
let's see on fluoro how it looks like. It seems okay to me.
Yeah.
We also we are a little bit old-fashioned. We like to combine the echo, but also what we see on fluoro.
So the overall trajectory, I think Didier looks good.
It's good. What's your opinion, Lars, Becky, Jeff?
And ask Becky, what do you think, Becky?
Yeah, I mean, the transeptal was just perfect. So it was right at the medial commissure, just really, really lovely. And then the commissural view might need a little more forward rotation because we still see a lot of right heart. And then you see the entire guide, so which you may not be able to get the guide out because it's actually quite nicely positioned. I guess my only concern is that the TEE probe is so perfectly positioned just behind the guide that my one fear is that the acoustic shadowing from the guide itself is going to prevent you from seeing the arms. So sometimes we'll go a little bit deep and image it a little off axis and then just use a single plane in the grasping view. But we'll have to see once the clasps are open.
Okay. Okay. Excellent. So maybe we can. What we're going to do, we're going to follow your advice, see what's going on. We can Okay, we may start like that, Nico, and see what we see on 3D. Sometimes the 3D on fast view of the mitral helps you. So I'm going to keep that position. I have all the landmarks, the position of the guide with the flush port, the position of the steerable with the fin. Okay. I know what are the orientation.
So I can go to the capture ready position.
I will let you comment.
Yeah. So now I will just come back to the multi-planar view 1 second.
Just to explain. Thank you, Laurent.
Yeah, thank you, Laurent.
Try to.
So what we want now, simply speaking, is to open the PASCAL device, to open the paddles, and to assess the clasp function. Yeah. So what I'm going to do, and you can follow that under fluoro and also under echo, is just open to the capture ready position. So you see both clasps, but opened. And what we're going to try is to focus on the quality of the echo image for the procedure and for you.
Yeah, just try to optimize the image just to make it more visual.
Maybe Laurent, focus on the LVOT image only, rather than multi-planar view.
Thank you. This is
okay.
Better.
Thank you. And now we're going to assess and to test the clasp function. So I'm going to descend both clasps at the same time first. Pull on that again in order to assess that. So I'm currently doing that by pushing the sliders.
We saw the both clasps coming down.
Okay. Up. So we perfectly see the posterior one and the anterior. Yeah, the anterior also. Was it clear for you in the room?
I think it was very nice. You saw how these clasps are going to engage leaflets between the paddles and the clasps. So,
okay. And now you see in my right hand, I have two sliders, and I have as operator to understand which one is controlling the anterior of the posterior. So, keeping the same projection, what I'm going to do is to maneuver only one for us to understand who is the posterior and who is the anterior. So here is this one, and you see this the anterior valve sides. So I know that this slider controls the anterior clasp.
And this is really one of the beauty of this system. It's differential capturing, and in some very complex situation with the high tethering, it's really useful. So maybe Laurent, you could show us the 3D fast view, and we're going to show once again the movements of the clasp, and if we're going to correct the perpendicularity of the IC, and then go for the capture. So meanwhile, if you have any comments, so please feel free.
Just explain what we're looking at on this 3D view. What is what? What's anterior, posterior, medial, lateral, and what are you aiming for with the device?
Okay, again. So maybe Laurent will put, while we are explaining that, some labels on the 3D view, but mainly, you have here. Perfect.
You see the anterior.
Okay, so you have the anterior parts of it's a surgical view of a mitral valve. So you have on the top of the image the aorta and the anterior mitral valve. On the bottom, the posterior mitral valve. On the left of the image, the lateral parts of the valve, and on the right, the medial parts.
Yeah.
And at the bottom, what we see is the PASCAL device just above the mitral valve. And just after the PASCAL device, you see, it's made a little bit hardly to see, but we see the coaptation line of a mitral valve. And what we want at this step is to ensure that we are located at the place of a disease, of a prolapse, and that we are quite perpendicular to the coaptation line.
Okay.
So regarding the disease, Didier, I think we're just in front of it. That's why we no longer see it. Huh?
Yeah. Let's put briefly some color, please, guys. Color. Thank you, Laurent. So the location looks
looks
okay.
good.
Looks good.
And regarding the angulation, what do
The
you think?
angulation, I guess we are not that
Without
bad.
color, you can skip the color?
Yeah, we could, I think you have to rotate a little bit counterclockwise the IC, just to be a little bit more perpendicular. Yeah, clockwise. Sorry,
yeah, sorry, clockwise.
Yeah, clockwise.
So Didier, I'm doing
What do you
this.
think about the trajectory? It looks a little bit like to be more to the posterior leaflet, so maybe we have to a little bit to change the
Yeah, you're
trajectory
right.
We will change that after.
Yeah, you have to go, you're right. We have to correct and go more anterior. So Didier is currently doing that. Yeah, rotating
And
the.
it was even a feature that was necessary because as Nicolas was rotating clockwise, just to allow that clockwise rotation to reach the tip of the steerable and to be applied to the IC, I had to correct a little bit counterclockwise. So
Maybe a little
I'm
bit
already
more
moving a little bit anterior, but we're going to see it better on the X-plane view.
Okay.
Okay.
So let's come back to the.
And let's see. I like always to record to see what is the aspect once we have on fluoro.
Okay.
Okay, we're a little bit close to the valve. That's why we have such a movement. Okay, let's go back to the X-plane, guys. And maybe once again on the X-plane we can put another run of color just to see where is the jet, if we are happy with the position. I'm going to back a little bit the eyes here because we are touching the mitral and it's going to be more obvious for you. Okay, couleur, Laurent.
Okay.
So on color, it's
good.
It's good, yeah.
Okay, you can skip the color.
On peut enlever la couleur.
And now I think we can
focus on LVOT.
Yeah, focus on LVOT. And dive in the left ventricle. Okay, Didier, so I follow you.
Yeah.
So as
we
you
just
go
see
forward,
the
are you
LVOT.
closing the device or are you just leaving it?
A little, yeah. I've closed a little bit. I was in a capture ready with a Clasp with the paddles totally horizontal, but you see its anatomy is quite small, huh?
Yeah, yeah.
So I mildly, slightly closed a little bit the paddles to maybe different angle, but really slightly.
Okay. So we're going to dive a little bit, go below the mitral valve. There is a little bit of, okay. It didn't seem that we moved a lot. Let's go back to a nice LVOT. Maybe, Laurent, you can zoom more on the IC and the mitral.
So Didier, is the plan to grab both anterior and posterior leaflet at the same time, or will we use the independent grasp features independently at the beginning?
No, what we're going to do is to grasp both at the same time, and if it's too complex, given what we see in real life, we're going to go for the differential capturing.
Yeah.
And so we really capture simultaneous capture, and then if it's not simple.
So GJ, on fluoroscopy, it didn't look like it rotated as you advanced it forward, but are you going to check once again on 3D that you're still in a coaxial alignment?
Yeah, it's a very nice advice. On fluoro, as I said, we like to combine fluoro and TE. We don't have the feeling that it rotated, but we're going to check on the 3D. We have time, so let's do that.
Just explain, what do you see here? What do you think?
Yeah.
So what we see is also still the same. You have the aorta at 12 o'clock, and then the posterior aspect of the mitral valve at 6 o'clock, medial at 3, lateral at 9. And we see the EIC, the implant that is below the leaflets. And when we watched, as we're aiming at the A2P2 location, the IC should go run from the aorta towards the posterior aspect, which is more or less the case. Maybe a slight counterclockwise rotation
yeah, a little bit,
could be applied. So I will let you...
no, do it, DJ, because you have to compensate the maneuver.
Okay, I guess like that it's okay.
Okay.
So it's a minor... okay, let's go back to the LVOT view now. Thank you, Laurent. Okay, and zoom in a little bit just to make it more visual for you guys. And as Becky said, we have a little bit of shadowing because we don't really nicely see everything, but we're going to try to optimize that.
Yeah, maybe push in a little bit and then mechanically rotate forward another
rentre un peu
20 degrees.
Yeah, it's important before to try to grasp the leaflets and to ensure that we have the,
we have
the
a
better
very nice imaging.
as possible.
So that's crucial because we have to make sure it's improving. We have to make sure that we see both leaflets, both paddles, and we see the movement of the clasps. Once we have the clasps capturing the leaflets, here it's better. So it's really important to get time. What did you do, Laurent? It may be interesting for the audience. Did you follow the advice from Becky, going deeper and then rotating? Did you went deeper with the T probe?
Yeah, exactly.
Okay.
Okay. So we see Didier that we are located now at the place where we have the ruptured chordae.
Yeah, exactly.
See, huh?
We see the chordae going back and forth.
Okay. We see the anterior leaflets opposed to the anterior clasp, anterior paddle, and dancing on that.
Zoom.
And we see the posterior leaflet also. On the paddle with a ruptured chordae. What we see is that maybe we miss a little bit of
perpendicularity.
of posterior leaflet in the posterior pedal. So maybe you could go a little bit more posterior. What do you think?
So just like that.
But we
and
pull a little bit.
It's better.
What about your experience to close the
I'm going to descend the clasp.
Vas-y.
Yeah, we can do that, but I'm going to descend the clasp now.
Okay. So then I'm advancing a little bit, and we're going to search for bouncing. First, we have to look for some bouncing, but it seems that the posterior...
Yeah, the posterior is out, I think. And we saw that we had a kind of folding of a posterior leaflet at the time we
had the clasp. Explain that for the audience, please, Nicolas, because it's quite important. This is something that we've learned with that device.
Yeah. So I think if we now look at the image, we see that the anterior leaflet is inside the device, and we see the bouncing of the anterior clasp. But we saw that I don't know if you had this vision. We saw that at the time of descending the posterior clasp, the posterior leaflet was kind of folded,
curling,
and finally was out of the device. So we have two options. Either we remove the two clasps and go for another attempt.
Leave the both clasps at the same time, but let's try the differential.
Or we can try a differential. So if we have the anterior. So what I'm going to do, if you see my handle, is that I'm going to remove the slider pin here and just remove and go up with a posterior clasp.
Here. And I'm going to correct a little bit more posterior. You see, advancing a little bit more posterior.
But you see that I'm not sure that we are not above the clasps. We perfectly see the bouncing of the anterior one. But for the posterior, I think we're a little bit above.
Yeah, it's above.
So what we could do is just raise the two clasps and go for another attempt.
Okay, let's do it. So we have to both synchronize them.
Okay. We can raise the two.
And then we were going to correct, maybe focusing more on the on the posterior first. Okay, posterior is in. I'm going to correct for the anterior. Okay. The anterior is not really in.
No. Maybe have a look at the fluoroscopy also to be sure that we have not rotated.
Now the angulation is, the rotation is nice. Okay. So let's take time just to capture both leaflets. It seems that it's better. The posterior is still more challenging here.
So, Cheche, what's your experience regarding the independent leaflet grasping? So you go first with the PML?
First with the posterior, and then here it's as most of the challenge was grasping, was capturing the posterior. We may capture first the posterior and then go to the anterior.
Yeah. Okay. This would be your advice to do that?
We're gonna do that. We're gonna do that. Okay, Nico. So let's capture first the posterior. Posterior is in.
Okay. So I remove the slider pin.
Let's take advantage of the feature of the device.
Okay. And I'm descending the posterior clasp.
Okay, so we see the bouncing now. And now we're going to correct anterior and try to.
But we lost
and
the
the
posterior.
okay. Let's do it again. Let's lift. And we're going to restart first the posterior. Okay.
Maybe we don't have to fold too much the posterior, so that's maybe one of the reasons why we lose it.
Okay, let's do it.
Okay.
Posterior clasp. Down. And we lose it. Okay. Okay, let's do it again. So we will take time.
So maybe Didier, we can also try a slightly different position in order to
maybe to be a little bit more perpendicular, more, and
to change the trajectory to anterior position could be help.
Exactly.
In this case.
Exactly.
Exactly.
Yeah.
And half of our cases, so we did an independent leaflet grasping, and we started with the anterior leaflet because it's much more longer, and you have more possibility to change the trajectory as long as you have captured the AML.
Okay. Okay.
So it seems while we were discussing, I changed a little bit the overall trajectory by moving a little bit, flexing a little bit more the guide, just to get a little bit more height, and then I corrected with the IC.
Okay, so the anterior now is in. I think you can pull a little bit more, and maybe the posterior also. No.
Let's see.
So let's listen both, huh?
Yeah. Let's do both at the same time, and then we'll see. It seems that
I think the AML is folded a little bit, and it's not down to the apex at the moment. So
yeah. We can pull a little bit more, Didier, on the device. Okay.
Here it is. So let's try it here.
With both or only?
Both I would do, and then we will correct if the posterior is not.
Okay, both.
Okay, we see some bouncing. Okay, let's release a little bit the tension. We see the anterior clasp bouncing nicely. Let's see on fluoro what we have. Okay, we see the bouncing, and then the posterior needs to be corrected.
Yeah.
Okay.
We have this issue, so I'm raising the posterior.
Yeah, it's better. It's better. Just the posterior.
Okay.
I'm gonna correct a little bit towards the posterior leaflet. It's all the challenges of DMR cases.
Okay. Here.
Yeah.
But you see it's a little bit folded. Maybe
it's curling, so maybe we are capturing too much of that leaflet.
Yeah.
Sometimes one trick could be that you just close the device a little bit to a 140 or 120 degree position, and then the leaflet could slide down to the apex.
Sorry, we were discussing what was your advice?
A little bit.
No, sometimes it's better to close the device a little bit, just to a 140 degree position, and that could help that the leaflet could slide into the apex.
Okay,
so now the posterior clasp is fully up. Let's aim at getting it into position. Okay. Okay, Nico.
Okay. And now the posterior.
Release a little bit the tension.
Yeah.
Yeah, the posterior is challenging to capture. So
yeah.
Let's try it again.
Okay.
We have that differential, so it's good because we don't have the anterior to deal with now. So it's one aspect. So we're going to optimize a little bit the echo image just to see the posterior. And let's move a little bit more posterior. And let's take time. It's really necessary not to rush. Once we have a good LVOT view. Okay, don't move, Laurent. Thank you.
Okay.
Okay, so a more posterior, rotating posterior DIC.
Okay.
Okay, close a little bit more.
Yeah.
And clasp down and bouncing.
Okay.
Excellent.
That's got it.
So now we see both bouncing of both the leaflets. What we're going to do, I release the tension, put some color on it, and let's close a little bit more because it's... Okay, cool, nice.
Okay, do you want me to fully close the Didier?
Okay. I think we are kind of splitting everything, so maybe you can go to the closed position now that we have everything, Nico.
Okay.
Et en couleur, s'il vous plaît. On color, what do you see? It seems that we still have some jets. We have to determine if it's medial or lateral.
I think we have to have a wider assessment, a wider view, maybe with a multiplanar view, in order to understand.
Becky, what are you looking for at this stage?
Yeah, I mean, they ended a little medial, and the flail, largest flail is a little lateral. So, if you keep this, it's okay, but you're going to have to put another device in next to it. The other option is just to move it over a little bit more
we're
lateral.
Going to optimize. Reviens en LVOT, s'il te plaît. Reste en explain sans couleur. So we're going to
try to optimize the position. Huh?
So open capture ready. Okay, thank you, Nico.
And
the
clasp
up. And as the trajectory was quite nice, what I'm going to do is to push a little bit the steerable just to be a little bit more lateral. Could you show us explain with the bicommissural, please?
And there's a fair amount of retrophasic movement, and sometimes we'll do this on a breath hold, but you have to reposition on the breath hold too, because it'll usually bring it medial. So you want to be lateral. So.
And this is Philip. Hi. And you might want to double check on 3D. I think now you lost the clocking.
That's what we were discussing. Hearing the comment from Becky, we're going to go to 3D just to make sure that the clocking is appropriate, and that I pushed a little bit the IC just to be more lateral.
So maybe
the clocking a little bit more clockwise.
Clockwise a little bit, huh?
The device is at 11 o'clock now, and you wanted to have it at 6 o'clock.
You want it better now. Okay. So let's go back to the.
Je sais pas s'il a répondu.
Okay, it's okay like that.
And go more anterior.
Yeah. So let's go now a little bit more anterior. Sorry. Okay. Could you focus on the LVOT? So we just now are going to focus on the LVOT. We were a little bit more lateral.
We found too that the release and recapture is a little more forgiving with the Pascal device. That seems to be a little bit less traumatic. So I think the right decision to try to optimize at this point in time rather than put a second.
Remets-toi en 3D, Laurent, s'il te plaît.
3D. So let's check the clocking first because we don't.
Trajectoire vachement poussée, tu sais, comme ça. Yeah, so you see there was a kind of inertia. So when we compensated our clocking, the device kept on turning a little bit.
Yeah, that's why we have to reconsider.
To correct that and to go more posterior also.
Okay. So let's go a little bit more posterior now.
Okay, that's good.
Thank you, Laurent. So I'm going to hold the position, and while Nicolas will activate the class. If you can zoom in, Laurent. It seems that we are in a better position now.
Et en LVOT.
LVOT, s'il te plaît. LVOT view. Okay. So if you can center everything. Okay, it's going to be better, I guess.
We were too posterior.
Posterior, we'll go a little bit more anterior.
Okay, dive a little bit to be sure that we see the leaflets resting on the pedals.
Let's just optimize the picture. Okay, Laurent. Nice. Nice like that. It's visual. Okay. I guess it's okay. Let's see the anterior. Optimize a little bit the anterior. Both are on top, I guess.
Okay.
So let's lift.
No, the posture is not
the same.
Longer.
Okay, so let's load first the posterior. I'm going to move a little bit anterior.
Okay.
Okay, try to keep the picture, the image still. Okay, clasps down.
And both clasp down, yeah.
No, we didn't.
We did not see them, huh? going down. Yeah.
Okay, so let's go a little bit like that. Okay, so we are up. Yeah, please, Philippe, please. Okay, let's try here, Nico. Bouncing on the anterior and posterior now. You see the bouncing, we have both on the anterior, it's okay, and the posterior also. Okay, Laurent, could you show it? So if you zoom, you can see, watch the posterior clasp is on the posterior left part of the screen. The anterior clasp is on the right part, and both are opening and closing.
What about the clocking at that stage? Just to check it, to recheck again?
Yeah. En 3D,
you can recheck.
Before closing.
Posterior.
But it seems that we didn't move that much, given the fluoroscopic image. So I'm quite happy. I'm quite happy with that. But we follow your order.
So we can close.
LVOT plus color, Laurent, please. And then we're going to close and see.
Can I close, Didier?
Yeah, you can close, Nico, I guess. With, zoom un peu dessus, s'il te plaît, Laurent. And we see the dynamic.
Okay, we're close.
Release a little bit the tension. So maybe we'll have to put a second Pascal more lateral, because we did move lateral. We still have a residual jet, but at least we could demonstrate all the features of the device. So let's assess what we have. First, vous pouvez zoomer qu'on voit un petit peu mieux. Yeah, the amount of regurg. We still have a lateral jet, but we're going to put a second device. I guess that's going to be the option here, and it should fully decrease that regurgitation. Do you want to first check the gradient to see where we are? And then we're going to go to the 3D.
Regarding the second device, Cece, what do we think is the gradient after the second device? To which extent will we increase the...
In our experience, it doesn't change that much. If you are 4, you're going to remain at 4 or maybe 5. So the spacer really prevents extreme tensioning on the leaflet. So the gradient tends to be stable between 1 and 2 the Pascal device. And so we're not worried. If we think that the patient is going to benefit more from a second Pascal, we do it. If the gradient is about 4 or 5, it's not going to change. So here there is still a lateral jet. Yeah.
Becky, regarding the orifice area, do you have some experience to which extent you can reduce the orifice area with the second device?
Typically, again, a single device is somewhere about a reduction of, it depends on if it's functional or degenerative. So the degeneratives have much more mobile leaflets. You're going to reduce the valve area less with a single device. And then when the second device, if it goes right next to the first, which this one will, again, we will not see a huge difference in reduction, maybe another 10% down reduction. And again, with the degenerative disease, really just a lot less reduction than functional. Functional, we find the gradients go up, you really reduce because you're tethering everything again. And so you want to be a little bit more careful. This has got a big valve area. I think it's really well positioned, the first device. So now they can come across and go lateral to this one and really close it down, I think, with the second device.
So, Philippe, what we want to get rid of the mitral regurgitation, but not to create a mitral stenosis. So we measure the mean gradient. It was 3 millimeter mercury now on assessment. What is the threshold? How much can we accept?
As a final result, I'd really like to see the gradient not to be more than 5 millimeters of mercury, but I totally have to agree with everything which has been said. I guess at the beginning, because it's a little bit of a bigger device, sometimes we were misled and thought that this will end up with high gradients. But because it has some compliance, and despite the fact that you achieve quite a thick tissue bridge, the leaflet mobility beyond that bridge is actually quite well preserved, and this is why, as they said in their experience and in our experience, when you implant a second device, the gradient sometimes does not go up at all, or maybe only 1 millimeters of mercury, because you also have to consider if you take away some regurg, that also helps you with ending up with good gradients, low gradients.
Hendrik, we were looking at echocardiography to see what was the outcome here, how much reduction was. It's also possible to measure the pressure in the left atrium. It's been more and more common. Can you comment on what are we looking for with the pressure measurements?
Yeah, many people do this now through that same access to have in pigtail in the LA. What is a very good achievement. I think it's easy to do, and it gives you quite worthwhile numbers. I don't know if they haven't done it here now, but I think it's easy to apply this to every procedure. And what you've seen here, I think it's quite interesting. In the flail leaflet, it's very hard to grab. So if you aim for the flail, you've got to come with some procedure. Maybe if you need a second or clasp anyway, it's easier to start a little bit medial or lateral and then have a nice and easier clasp and then go for the second clasp right after.
Holger, any rules? Start medial, go lateral with the second, or start opposite? What's recommendation?
Normally, you have to go more medial with the first Clasp PASCAL, and then with the second to the lateral. Yeah, it's the better way to do.
Yeah. So how much regards do we have left here? Looked on echo, Becky.
I mean, it was a very large flail. So remember at the beginning, just the width of that flail segment, one would have anticipated you might need 2 devices. So it would have been, I think, surprising if they'd been able to do it with one. And so I think this is now perfectly positioned to reduce. It's already been cut in half. And I think one of the other things that we like to do is look at the pulmonary venous inflow. My guess is there was a significant amount of reversal. And now we might see blunting. And then with the second device, you may actually see systolic dominance. And that's just a reflection of left atrial pressures.
So what the team did here was what most team will do. You will start with one device in the middle to see if you actually have a good result. If not, you open up, you go a little bit medial, place it here, and place all the regurgitation on the left side, the lateral side, and then go with your second device. So we can go back to DJ and Nicolas and ask what the strategy is now.
Now the strategy is exactly what you discussed and what you mentioned. The strategy now is to treat the residual prolapse that is explaining this residual significant regurg, putting a second PASCAL device in a lateral position as compared to the first one. So you have actually the multiplanar view. We can add some color on that for you to visualize. To visualize where is the residual jet, and you see that it's in a lateral position relative to the first one.
So let's check the trajectory.
Trajectory, Didier, maybe we are diving a little bit too much from lateral to medial position. So
I'm going to release a little bit of the medial and the flex.
Yeah, and pull everything out.
Okay.
Yeah,
so that's
a little bit. Okay. I'm going to go to the capture ready, and we are to posterior.
We're to posterior now.
For the clocking of the device, of the second device, do you still rely on a 3D, or do you just make the best out of fluoro now and use the first one as a landmark?
I think we can use the fluoro.
Yeah, we can use the fluoro just to achieve that.
Un peu plus au-dessus.
Here we are. Okay.
Okay. We're going to check un peu plus haut parce qu'on est sur la base. And we see that we're totally perpendicular to the first one, so we can directly correct that, Didier, in order to be well aligned.
We'll still use the 3D, for a couple reasons. One, we don't want to get too close to the first clasp, and so you don't want to run the risk of hitting your first device.
Okay.
And so sometimes the 3D will really help you direct your guide, and then also check trajectory.
And then the other question is, if you elongate the device, you would have an even lower profile. Is that your strategy for the second crossing?
It's exactly, if we want to cross, we have to elongate the device. It's not inverting, it's elongating.
Okay, so you see the clasp testing?
Yeah.
Okay, both are descending. I have to check now where is my anterior clasp control. So again, the same maneuver.
Yeah, the anterior is anterior, it's okay.
Anterior is anterior, it's the one. Okay.
That's fine. So let's elongate it, Nico.
Okay.
And Laurent, can you go back to the free LVOT?
Et on va arrêter la ventilation.
And stop ventilation. David?
Okay.
Merci, c'est bien.
Okay, good.
So we go down elongated, and that's one of the features of the device. We're going to go back to the capture ready mode.
Okay, that's fine,
A little
Didier.
bit more, Nico. I'm okay with that. And then focus on the LVOT. Maybe we'll need to correct a little bit.
Check the clocking in 3D maybe again.
Yeah. Okay.
On
So let's
3D.
go back in 3D. We have 3 minutes, 5 minutes, so it should be fine.
No, you have time. Just take your time.
Cool. So we need to check first the clocking.
Oui, un peu trop près aussi, pousse un peu tout l'ensemble.
Okay. Yeah, it seems that we are not
The
that
device
bad.
might,
Difficult to see.
It's difficult
Difficult to
device
see.
is-
There is
Yeah.
shadowing. But
the device is a little bit deeper. You might want to
I'll
just
figure that. If they can keep
move the
going.
Yeah.
move the
Yeah.
3D
Yeah.
box into the ventricle a little bit more.
Okay, and
Yeah.
it's a little bit close also, so
Yes,
that's why
yes,
you,
yes,
you
yes.
have difficulties to
Yes,
see.
yes.
So I open it a little bit more, and it should be easier to visualize it now.
yeah, so we have to now put the cursor really on the second Pascal.
So Philippe, it's not parallel with the first device. Is that a concern? Should you try to get it more parallel?
Yeah, in most cases, if the second device
can
goes
transfer
next to the
on a
first,
peu trop
then it should be almost parallel. So if
Yeah.
imaging on echoes is difficult here, I would focus on fluoro and try to
On fluoro.
get
Yeah,
the same
yeah.
orientation.
Mettons en fluoro. Okay, we're going to do that.
We're
you're
going
right.
to use the fluoro just to, okay. Maybe more like that.
Okay.
Okay, so let's go back to the let's go back to the LVOT, please. And just try to focus on the second Pascal. Could you zoom in, guys? Just a little bit.
And
Just for
focus on the
audience.
second, yeah.
And focus on the second one, yeah. So I need to go a little bit more posterior. There is a kind of interaction with the first one, but it's
Yeah.
Did you consider
Maybe-
moving
did you-
everything a little bit further in and have more flags to be?
Yeah.
It's exactly what I did, what I'm doing. Thank you.
Color be helpful to see,
Just to be,
see where the jet is. See if you're over the jet with a little color on
Okay,
it.
just focus on the. We're gonna focus on the second implant,
Okay, that's
and then
fine.
yeah, we need to be a little bit more. Okay, anterior. Okay, just focus on the implant, and then it's always more difficult when we have two implants. Okay. I
Okay,
think
guys.
we are,
Yeah.
yeah, we are happy. Let's
The posterior for sure is
posterior
in.
is there. It's more the anterior.
Anterior, I'm not sure, yeah.
Okay, I'm rotating more anterior. Okay. Let's see
Okay, let's descend the clasp.
to see if we have bouncing of the anterior.
So for the
The posterior
posterior
is fine.
Yeah.
It's sure, and we will have to. We need to.
To optimize
Yeah,
and
optimize the
to
anterior.
control the anterior.
Okay.
So, okay, we're going to open only the anterior
Interesting
clasp.
case.
Okay,
Interesting case. So let me optimize more anterior.
maybe
Go down a little bit.
yeah.
Okay.
Okay,
Okay.
pull a little bit,
Je pull
think it's fine,
a lot
Didier.
down. Yeah.
and let's go with the anterior.
Yeah.
Focus on the anterior, guys, at the for echo. Mettez-vous sur le. Okay. No, I'm not sure, but you see where the leaflet.
We are a little bit. Yeah.
Yeah.
Okay. So let's lift both clasps,
Yeah,
and we're
yeah.
going to repeat again. We need to correct a little bit
I
the
think so. I
trajectory
think so.
because we are not really perpendicular.
Yeah.
So let's not flex that much.
And we are a little bit far now from the
Yeah,
second
from the
implant.
the
You
second
see, huh?
one. So let's
We have
go
moved
back
a little bit far.
Gigi and Nicolas, can we suggest that Philip is giving his talk now and you can work and we come back to you in 10 minutes?
Yeah,
Yeah, okay.
great.
Yeah.
So let's
Yeah.
just try to. Yeah. Okay.
We can do that.
So Philip Loers is going to give us an update on how the Pascal repair system impacts my daily clinical practice. We've had a good practical up until now. So Philippe.
Yeah, thank you. It's my pleasure to share some of our experiences so far with this device. This device entered real world, and more than several hundred procedures performed so far. In our own experience, we've performed 47 cases with a follow-up of at least 30 days. The average number of implants at our institution was 1.5, so you see that it's not necessarily, and as also in that live case, it's not necessarily a one-device procedure, but can also be a two-device procedure. The average procedure time was 68 minutes, with the second device going in much faster than the first. Once the first is in, the second then on average took only 11 minutes. When we assess procedure success, I think that many of us move away from looking at moderate or less and consider success actually mild or less mitral regurgitation after the procedure. In these cases, we had a procedure success of 88%. The gradient, which was considered to be good below 5 millimeters of mercury, 96% of cases with an average mean gradient of 3.1. You can see that we treated a variety of conditions, more FMR patients, but also DMR and mixed etiology. And I'm going to show you 4 different cases highlighting some specific aspects of that procedure. Starting off with the functional mitral regurgitation, really severe. You can see that jet expands almost across the entire commissure. This was a quite young patient, but an ejection fraction of only 15, and I think a good candidate for transcatheter repair. Because of this very broad jet, our initial strategy was from the very beginning to go for a 2-device approach. You can see here that the first device is in and has been released already. The second device is still attached to the delivery, to the implant catheter, and on the right is the final result after release, which was actually quite satisfactory in this case. And I would also like to make the point, this system is very flexible. It is it's very flexible, and therefore, in most cases, we do have the same result after release than before, so it's quite predictable with what we will end up. Gradient, 2 devices, but quite large valve, so the gradient after the second implant, 2 millimeters of mercury, and then no further change with the second device, which can be explained. Obviously, the opening area is smaller, but at the same time, we reduced MR to a significant degree, and that will then end up with the same gradient. Next case, a little bit more complex anatomy. Becky Hahn showed that ideally for these repairs, the pathology should be in segment 2. What you can see here that, yes, there is a prolapse of the anterior leaflet in segment 2, but this extends also towards the segment 3 and right towards the commissure. You can also see that here, so central prolapse and a commissural prolapse. What we did here, we weren't sure what's the main lesion, and although it has been said before that normally you start in the center, we start here medially, we put that one in at the commissural place, and then a second one at the center of the valve, and that was the final result. Again, a good result, I believe. But this procedure obviously does not only work in segment 2, but there are no reasons why it shouldn't work in segment 1 or 3. Okay, next case. This is not so much about the reduction of MR, but it's, I would like to make the point of leaflet mobility, and we also see that in this case. This is a patient with FMR, again, with some restricted leaflet mobility. And here you can see that we implanted one device, A2P2, and this is the opening area afterwards. But you can see here that there is quite a thick tissue bridge, but beyond that, medially and laterally, the leaflets are really opening and closing nicely with very little restriction of the motion. And this is how you can end up with still an opening area of 4, despite the fact of producing such a tissue bridge. And then the last case, this is a case with multiple lesions, which is quite a challenge for any repair technique. The main lesion probably is here in the In the central part, again, this is a P2 flail, quite an extreme flail. Here you can see the width and the gap. We approached this lesion with a sequential grasping approach. Here you can see what it looks like afterwards. But then after treating this lesion, the more lateral lesion became more apparent, and we did not want to leave that untreated, so we tried to implant a second device. This device now with quite some distance to the first one, so obviously we made sure that we will not end up with very high gradients. That's the result in terms of MR reduction, and this is what it looked like afterwards. So we had now 3 openings, one in the center, one medially and one laterally, but in between really good opening and good leaflet mobility with a gradient of 4. Obviously you also measure the opening area. Sometimes this can be difficult, especially when you have 4 devices in. With the gradient, and this is a little bit borderline, before we end the procedure we try to have blood pressures which are realistic to see whether we underestimate the gradient. So when I'm saying the mean gradient was 4, this means that that was under conditions and a blood pressure which is equal to the one when the patient was admitted to the hospital. So in summary, well, first of all, this device gives us more options, and it's on all of us to find out how to make the best out of these options. In our experience, the result from pre-release to post-release is really quite predictable. It has an excellent safety profile. We can apply it in a wide range of different anatomies. The independent grasping is certainly helpful in complex anatomies, but the bigger role of that is probably the single leaflet optimization, meaning that you first grasp both leaflets at the same time, and then you optimize the one which is not ideal. You can approach multiple lesions, and because of this compliant device and the preserved leaflet mobility, you end up with acceptable gradients despite a quite thick tissue bridge. Thank you very much.
So Philippe, is it your impression that you can actually get a better tissue grasp with the paddles and the spacer, or is it about the same amount of tissue bridge that you get with the 2?
It's not easy to measure if you really want to objectively assess that. It depends a little bit on the anatomy. I think the tissue bridge is similar in many cases, but the restriction of leaflet mobility, that varies a little bit. And I really try to make the point that just next to the tissue bridge, we have almost no restriction of leaflet mobility. And in some cases where you grasp really a big bite of leaflet, you see that during the cardiac cycle, the device is opening and closing just a little bit, implying that it allows to preserve the compliance and the mobility.
Good.
But just there's a few questions from the panel, for the audience here. When you do this grasping, how much leaflet tissue do you ideally want to have captured?
Well, yes, this is an important point. The way the leaflets are grasped and the closing mechanism of this device to be really effective, it is important that the leaflets that they touch the apex of the spacer. So you really should make sure that you get as much leaflet in and that the leaflet is touching the spacer. If you do so, then normally you will end up with a very good result, but that's something to make sure.
Yeah. I think we saw an example of that too with the folding that happened with the first grasp, is that sometimes the leaflet goes in, folds rather than gets down into the apex. So they did, the team did a very, very nice job getting into the apex.
Should we go back to Toulouse, I think? So.
Great, thanks Philippe.
Gigi, Nicolas, can you hear us again?
Yeah. Hello guys. So we listened carefully to the talk from Philippe. Meanwhile, what we did, Nicolas, myself, and Laurent, was to change a little bit the trajectory to be more perpendicular to the mitral valve. It was more feasible to capture the anterior mitral leaflet. So we have 2 PASCAL in place. There is a mild regurgitation. We're going to assess that all together. We want to see the gradient So you have the gradient live. It was free before, and as we were discussing, Philippe, we said that most of the time when you put a second implant, you still remain in the same range. It was free. We are at 3.5 of mean gradient, so that's nice. You see, we are still attached, so we can see the 3D with the orifice, please, and then we see we can put some color on top to see what's remaining. And to be honest, here the ability to have that differential capture of the leaflet was really useful for the second one, because we were once again able to capture more the posterior, and we had to work with a slightly better trajectory to go towards the anterior. And having the ability to both lift and put down the clasp from a differential perspective was useful. So correcting the trajectory.
Yeah. Maybe you can show us the 3D that is useful for everybody to understand what we have done.
So you have both Pascal ICs that are really
side
close.
to side,
Side to side. You see the spacers. We see that everything is closed. The paddles are really in contact with the spacers. The Pascal that is more lateral is still attached to the inner catheter, but we feel comfortable. It's going to be difficult to be more closer than that, Nico.
I think so. Yeah.
So if you put slightly color on this, please. Un peu de couleur, s'il vous plaît, les gars. So just in between, there is still a residual jet that is not massive. It's a mild regurgitation. So do you agree that it's going to be difficult to be closer? So as we can't be closer than that, we're gonna accept that. The gradient is nice. The final regurgitation is really nice. We can't be closer than that. Still the two orifices. So maybe we can release that one, Nico.
I think so. Yeah, I think so.
So
what do you
Lars,
think?
Philippe, what's your perception? Becky, Jeff?
Yeah, I think this is a very, very nice demonstration of a very planned capture of the P2 prolapse, and it was not easy. I mean, I don't think it was an easy case.
Yeah. Nothing is never easy till you do the case.
I think
Nico,
you did a great job. You had good imaging, but not perfect imaging, so that was more challenging. And in terms of the distance, I think at the level of cooptation, the two devices they are in close proximity. It's just that when the part which is in the LV, they point in different directions. But at the level of cooptation, you actually did a good job in putting them close together.
Just one comment about the distance. It may look like they're a little bit apart on fluoroscopy, but remember there's fabric around it, so often you don't see that. So.
And the other thing is, remember, it's still attached. So once it's detached and not being, constrained by the actual device, it may change position and become a little bit more parallel.
Yeah. We're gonna detach it. Okay, so it was a very, very interesting case. Yeah.
So a quick question from the audience, a kind of a technical question for you, Didier, is that because you had to reorient, was the location of your transeptal puncture in the right place, or could a different location given you a different trajectory?
So that's a very nice comment, but ideally, as we mentioned at the start of the case, you want to be just in the medial and posterior internal commissure. So the posterior commissure of the mitral valve. And we were exactly on top of that. If you are off axis in regards to that location, it may be more difficult. The thing that you have to change is the plane to be really parallel to the flex plane and to make sure you are parallel to the mitral plane. And this is achieved by rotating clockwise or counterclockwise the guide sheath just to make sure that you have that parallelism.
I think, Jeff, in this case, one of the difficulties was that it was an acute flail and therefore not a massively dilated left atrium and a very, very narrow AP dimension, so from aorta to posterior. And so, getting it positioned correctly when it's that narrow is pretty tough.
So Becky, there's a React PCR question for you. Is that after the repair, we want to measure gradients, but the comment is if we do the orifice areas, that it's not an accurate way of doing 1 + 1 = 2 for combining the orifice areas. Can you
no,
comment on that?
Well, we usually, because they're on different planes, we just do the orifices separately, and it gives us extra assurance and confidence that we understand the mean gradient. So that if the mean gradient is extraordinarily low, but the EF is 20%, and now your valve areas are planimetering at 1.5 total, you might think twice, you know. But again, if the mean gradient in this case is 3, I think it's probably less than 3.5, so 3, and it looks like you've got one very nice large orifice, then you feel more confident that the mean gradient is reflective of the actual valve area.
So, Gigi, Nicholas, we have to conclude the session in a minute. So, anything you want
Thank you.
to say before?
By the way, you have a packed crowd here in the main arena that has standing room only in the back. So you have many friends with you in the lab there.
So thank you very much for the comments. It was a very challenging case, and we really appreciated the feature of the device, being able to differentially capture the leaflets. The steerability was nice because we were able to change the location. And even with first Pascal in Clasp, the second one was feasible, and we could put both really in contact as much as possible, given the anatomy of the patient. So I have to say that overall, the final result is very nice for this particular patient. It's a very great result. So I would like to thank you for your comments, and thank my partner, Nicolas, for the quality of his support, and also Alison, Laurent, and all the team here. And thank you once again for the comments.
Thank you.
Thank you. Bye.
We've got a minute or so left. Henrik, what's a final comment from a surgeon's perspective about this, and how does it add to practice?
Well, for this particular patient, it's a great result. I mean, he's 87 now. He's got relief of MR, at least to a very important degree. So very good for him. I mean, I'm happy. For a surgical result, I would not be happy, of course, but this is not the point here. It's about symptom relief, and this guy will do better.
Good. All right, should we close, you think?
Yep.
All right, so I just have to say, our closing session objectives, we learned about how to use the Pascal repair device. We learned about the essential role of imaging. We participated in a step-by-step approach to the Castel device, and we reviewed some clinical cases that showed where this was going to fit into our practice. So I think we achieved all the objectives we had today.
Yep.
So panelists, thank you very much.